Hello and good afternoon to our audience members. Thank you for joining us for this session dedicated to exploring how anti-stigma work is predicated on anti-racism. As a quick reminder to our audience members, we of course welcome your questions for audience Q&A, which will close out this session. You can submit questions in the text box that's present below this video feed. You can submit those questions anonymously or with your name, whichever you prefer. Additionally, this session is approved for continuing education credit, but instructions for claiming that credit will be provided at the conclusion of the summit today. Finally, we will be sharing recordings of all of our breakout sessions to all registered attendees after the summit today. So if you are trying to pick a session to attend during this breakout, we will be able to get you all of those recordings. With that, it is my pleasure to introduce our speaker this afternoon, Tamika Spellman. Tamika began working with Honoring Individual Power and Strength, also known as HIPS, in June of 2017 after having been a client since 1993. She is now the Policy and Community Engagement Manager. She has featured op-eds in The Root and Medium and has testified numerous times before DC City Council and also advised congressional representatives Ayanna Pressley and Ro Khanna on proposed federal legislation. Tamika, thank you so much for joining us today. The floor is yours.
Thank you. Yes, again, my name is Tamika Spellman, and I will be talking about how I use my intersectional identity as a vehicle of change. Assumptions about who I am. As a Black transgender woman, I already have 2 strikes against me. But adding drug use into the mix, it becomes 1,000 times worse when I seek medical attention. Please, people assume all I want, need, and desire is to get high, that nothing else matters, so long as I get what I want, be lazy and live off the system while being a criminal and a burden to the system. Not knowing the whole time, I am a statistical anomaly. Black, transgender, a drug user who survived the crack epidemic, HIV crisis, COVID-19 pandemic, and still alive after 4 decades working as a sex worker. The drug policies alone harmed and hampered my life and my living conditions more than it did any good. And seeking health care was not much better. If I am in pain, treat the pain as I ask it to be treated. Reality of who I strived to be. All I wanted was a fair chance to thrive, to be a good parent, make my parents proud, and contribute in some small way to society. Well, society doesn't work that way. The bar for people of color is always moving, and there are holes in the system waiting to consume you at every turn. Nothing about my life has been easy, from employment to housing to surviving or raising my children to adulthood. I witnessed the change in education, watched wages go stagnant and union jobs disappear, all while police unions got stronger, drugs invaded inner cities where Black and brown folks lived in large numbers, and we became prime targets in the struggle to survive. In a 10 to 15 year time span, from the civil rights movement going into the mid-70s and early 80s, I witnessed the significant policy change that would shape the dumbing down of America and would ensue onto what we currently live with today. All the while, the medical professionals followed suits in regards to marginalized community members, especially those that are LGBTQ and Black or brown. What have you assumed your clients would be satisfied with? The reality. Perceptions are harmful. As a Black person, there are perceptions we face just because of the color of our skin. We were property, no different than horses and cows at one time in history, and not viewed as humans with emotions, feelings, wants, needs, or desires. But when we had the gall and audacity to want to be free, we had been blocked at every turn with the pseudo-freedom granted. We cannot go from being enslaved for hundreds of years to equal when we are categorically blocked and restricted at every step. The system has to be destroyed and we start from scratch in order for us to achieve true freedom and equal treatment. The perceived idea that we were livestock, not as sentient beings with feelings and emotions, led us to not being treated fairly or equitably by medical professionals who typically downplayed how we convey about how we feel. Reality of what it really is. We are humans with feelings and emotions that deserve the same level of care and to be attended to with dignity and respect. We should be heard when we speak the first time, when we share our feelings and experiences. How have you developed a treatment plan or perceptions? What was the reality of those treatment plans? Phobias interfere with professional and human interactions. Irrational fear of LGBTQ people of color who use drugs or are sex workers. The effects can be devastating. Reluctance to take care of our physical and emotional needs, feeling left out of the process of when receiving mental, physical, or medical care. Not being heard or respected when we say we experience pain or have emotional issues. Feeling inferior to medical professionals who do not speak in layman terms. What radicalized, gendered, and classed phobias are at play in stigma against substance users? Fear is often unrealistic and unfounded. Fear of violence, fear of language, unwillingness to cooperate, doesn't follow instructions or threats. The reality hits home. Sick, hurt, emotional, damaged folks can be mean unintentionally. Many LGBTQ folks carry weapons for protection, which many may balk at. It's not about you, it's about their safety when they are outside of these medical facilities. That does not negate the fact that they need help and sometimes don't know how to get it without speaking harshly. Many folks have had bad experience with medical professionals and put up walls in defense. Clients are allowed to be afraid, cold, uncomfortable, irritable when they are sick, but they are still entitled to care. We have to handle folks with kid gloves in order to treat them. I do so in my work, and I work with marginalized community members across the board, whether it be Black, brown, white, or blue. I work for people. I work for their betterment. I work with people that have mental health issues, people that use substances of all sorts. I work with people that are homeless, that are sex workers. And I take no qualms about the work I do. And I often reach out and I give them a hug because human touch is important. I went a little bit off script because that was important to me to say. Police and hospitals are not helpful to people who seek medical assistance. It is a barrier to treatment that are often dire and a reason why many don't seek help. I've experienced that multiple times myself, more so in the more recent past. You know, I have a heart condition and I go into this new facility in the city that I'm living in now. And I was shocked because there was an officer right at the door. Before I could get in, I had to let them go through my purse. You know, they're calling themselves looking for weapons. Okay, I'm a transgender woman. I am a marginalized community member that has survived when a lot of my friends that I came up with are dead because they were killed. I need to be able to protect myself. That weapon was not about coming in there and harming anybody in that building. I'm not feeling well. And that was a way of making me want to turn my ass around and go back home and not seek the help that I needed. These are some of the instances that I hear about from everybody that I deal with in the population basis that comes to HIPS. I advocate for these people and for these types of changes. If I'm still having these kind of problems as an advocate, and I can advocate for myself, and I try to put a stop to it at the moment it happens. But for them to stop me because I had marijuana in my purse and try to threaten me with arrest on the way into an emergency room, that was not appropriate, and it was definitely not healthy. What radicalized, gendered, and class fears do you see in response to substance use? Fear of contagion, verbal, physical, etc., violence, grifting, manipulation, etc. Because these are things that I have faced. These are my personal experience that I've been through in my 55 years of existence. I'm not a young person. I'm a little bit older, and I've had a lot of experiences because I've lived in several different places across this country. I'm from Buffalo, New York, currently living in Birmingham, Alabama. I work in Washington, D.C., but I have lived in the West Coast, in Sacramento. I've lived in New York City. I've lived in Chicago, and in Detroit, Indianapolis, Atlanta, Virginia, Baltimore. I've been around. And one thing that is certain, when I went to get healthcare, it was difficult at every turn. And I wasn't taken serious a lot of times. If I am one that's pretty smart, I research before I go and I ask for something. And I'm not going to take a medicine that's going to make anything else, put anything else in my body in jeopardy. I'm already taking drugs, and I tell the medical professionals about my drug use so that y'all don't give me anything that'll react with what I'm using. And it's like y'all take that and use it to your advantage to deny me access instead of thinking about it in the aspect of, hey, they're trying to mitigate their own harm. Because that's exactly what I was doing. I did not want any additional harm to come my way because I know if the doctor is giving me something and they don't know that I'm taking something else, that could turn out bad. So when we're out here and we're talking about how we're treating people, you have to think outside of those boxes, get outside of yourself and what your personal feelings are. If you're here and you're committed to making people feel better, to healing folks, then make that your priority and stay out of the small things. I'm kind of winded. So in summary,
go ahead.
Yeah, in summary, this is another one of what I call a Tamika Talk summation of the state of affairs. And I wanted to make sure that people have a clear understanding about gender identification matters. Please ask me how I identify. And then not only that, my chosen name recognition matters. Please identify me by the name that I have chosen for you to call me. I don't care whether it does not match what my legal identification is. You use that for billing information and for insurance. It is, what does it cost you to call me by something that I am more comfortable with being recognized as? Be affirmative and mutually agree upon the care. You just can't come in and say, hey, this is what it is, without giving me some options. And don't make me feel guilty if I decline. It is my right to do so, whether you like it or not. And that should not affect how you treat me in the future. People still have options to refuse care. Judgment and assumption-free spaces matter. I should not come into any medical facility at any time and feel like any of the people that work there are singling me out. That does not make me feel comfortable or welcome. Welcoming environments and courteous staff. That's a no-brainer. And it should be a matter of policy not to allow police on medical campuses. I've been through several different places, like I've said before, and some of the clinics that I've been through do not have security. Even at my job, we don't have security. We do not see a need for security. If something goes on, we come down as a team and we handle it. We're a bunch of adults that know how to mitigate the harm without being harmful. Because calling the police on marginalized community members is harmful to them. And it is also very racist, because a lot of those marginalized community members are Black and brown. And we have to get outside of that mind frame that these are the only people that can handle them. Use your mouth. Use your words like you would with anybody else. Because we can mitigate harm at my job. I know you can do it in a hospital setting because we have a clinic in our business. Okay, now I think I'm finished.
Thank you so much, Tamika, for that. We really appreciate hearing your insight and your experience come through in your statement. We have a handful of questions that we've received from our audience that I would love to pass by you and give you an opportunity to continue expanding your message today. First question that we received from an audience member, which I love, is what do you feel is the single most important way to show respect for those who I perceive to be different from me as a provider or clinical care member?
I would treat them like I would want to be treated, and not look at them any different. I would look at them like I treat my own children, like I treat my mother, my father. I treat them like their family. Because to me, we're all family at some level.
Absolutely. And can you maybe provide a little bit of kind of background information or context for our audience today on how anti-stigma work really can't be anti-stigma work if it doesn't understand and incorporate the way that the war on drugs and racism has impacted the population, I almost said patient population, but even outside of the healthcare system, the population of people who use drugs or use substances?
This really, the issue with it is based in the prohibition of it. It's about the control of adult behavior. And for number one, that is my number one reason for it's a bodily autonomy issue. And as a transgender woman who is also a sex worker, it also applies to sex work, and because of the skin tone I possess, I am more so a target of policing solely because of that. And it's an unfair practice that has been happening since the beginning of slave trading, because that is what the origin of the police departments. They were slave capturers. They were property recoverers, which is basically what police officers do today. They protect property. And when people start to do things that they criminalize, like back when alcohol was criminalized, it was prohibited, and it got more and more criminalized every time something would go on in history. And Black or brown people started doing it, it became illegal. And that's when they would clamp down on it. They would overlook it if it was our white counterparts to a certain degree. Because if you look at the history of mafia, they reigned terror for decades upon all kinds of business, and it was part of the American fabric. They were celebrated people. But when Black people started doing these things, then they have all these anti-mob laws and all these actions against them. There is a distinct link to the war on drugs and how the crack epidemic devastated Black and brown communities. I witnessed it myself. The neighborhood I grew up in, completely gone, devastated. And it was because of crack cocaine. Even though heroin was around for way longer, it was not specifically targeted to the Black neighborhood. And more so recent history, this newest epidemic of drug overdose and things all were led in by a legal drug. And that was OxyContin, those opioid related drugs that were legal, that were highly addictive, that were given out like candy, and we're not properly warning people of their addictive qualities. And then they snatch them away from people. And now we have this opioid overdose crisis because the supply is tainted with fentanyl. And we're seeing a more kinder and gentler approach to drug use and drug using now. And it is solely because it has crept into the suburbs, where there are larger numbers of white people that are being affected by this. But it was no kinder, softer, or gentler when it was crack in the urban areas.
Kind of related to that concept, can you talk a little bit about how anti-stigma work, as we're talking about it in the context of the summit today, how that needs to change and be flexible between different groups of individuals, especially those who are marginalized or vulnerable. The idea that it's not a one-stop shop or a one-size-fits-all approach. What approaches can our audience take away when they're working with vulnerable populations?
Number one, we need to stop criminalizing drugs, because that in and of itself stigmatizes the drugs and the drug use. That is the wrong approach to it. We need to be treating it just like we do marijuana and alcohol. You remember just a couple of decades ago, marijuana was frowned upon. But now that perception has changed because people can profit off of it now. And it should be the same with any of the other markets for drugs. We need to have it more so regulated than to make it illegal to consume, because people are going to do what they want to do, number one. And that is how you change the stigma and all the racism that's attached to that stigma, is by stop criminalizing it. It is an adult behavior. And in all honesty, equal amounts of Black and white people use drugs. Is really no difference. It's just that Black people are more so criminalized for it because we just happen to be more marginalized and a smaller part of the population, which makes it look like it's more activity when it's not. And the way to make that go away is to stop criminalizing, to take that away out of the mix of it and make it more mainstream. I feel like we should have drugs being distributed like alcohol is currently, and having like the distribution spot like a liquor store, and then we should have safe consumption sites like bars. Drugs are social. Alcohol is a social drug. Alcohol is a drug. Let me clarify that it is a drug. You mix a bunch of things and a chemical reaction happens. Drug. So let's clarify on what we need to do to remove these stigmas and take away some more of these elements that create the atmosphere for racism to breed. Legalize it.
Wonderful. We did get another audience question that came through, and I do want to prompt our audience watching today that, again, we are accepting questions, so please feel free to put those into the Ask a Question box below the video stream on your webpage today. But the question that we received here is, what are some effective stigma reduction strategies for Black, gay men, and or transgender individuals?
Say that again.
Excuse me, what are some effective stigma reduction strategies for Black, gay men, and or transgender individuals? I think the question is kind of asking, what can people do differently in their interactions with Black, gay men, or transgender individuals who present either to their healthcare setting or to their support setting that might be different than different cultural groups?
I don't know. I mean, that is kind of difficult I'm not understanding the question or something. Maybe the way it's worded.
Potentially. I think the question is probably getting to, are there strategies or different methods that can be used to help build kind of a feeling of togetherness and non-otherness with these individuals that maybe folks aren't used to implementing in their practice because they're not dealing with these groups of people.
I don't know. Maybe I could just say that if people would just realize that these folks that we're talking about can be family members. A lot of people don't know that they're family members shoes, and they hide it because it's been stigmatized. It should be a broader conversation about this. People should be talking about it to remove the stigma and thinking about this from a different approach. We have been beating our heads up against the wall for over 50 years with this war on drugs and have not won. It's not an attainable win. So it is time for us to reverse and go the opposite direction and just make harm reduction methods widely available. And then start treating this as we do alcohol, tobacco, other adult things. Put some regulations around it and move us in that direction. Have those tough conversations with people about the change that we need to make happen. The stigma is not going to go away unless we do something about changing the way it is today. That was where the stigma came from, was the laws that were put in place. I'm no different than anybody else. I wanted to work, but, trying to get a job and I have drugs in my system did not negate the fact that I could do the damn job. I can do the job. I work now in this capacity with this organization that does not penalize me for drug use. And I do a damn good job for them. So what makes people think that if we are high on the job that we can't do the job, or that if I might have drugs in my system that would hamper me from being able to perform the duties. You don't know if you don't allow it. And then guess what? A lot of people are already doing it and you don't know. And they're still doing the work.
Excellent. Here is another audience question. In your experience, how has stigma been addressed in your community to ensure people of color who may also face other intersectional factors feel safe and accepted in their community when seeking harm reduction support?
DC is a bit different than probably quite a few people's municipalities. We've been had the syringe exchange programs going on. We just got drug paraphernalia decriminalized across the board. So we are now able to pass out safer using supplies across the board for people that consume through smoking, because you can pass communicable diseases that way, and this is about the health of the whole city at large. If there's a contagion, we need to capitalize on halting the spread, and these are some more of the harm reduction methods that we use, along with a robust condom distribution. HIPS is one of the leaders in making sure that sex workers have condoms on the job because we take them out there on the strips. We have it in office and we have mobile. And the same can be said about the safer using supplies. We have them in office and mobile. We will deliver them to you, and then we do rolling stops. We have usual places that we make stops at to deliver, and people are receptive to it. And it's just like a normal part of life, which it should be available nationwide because it works. We brought down the spread of HIV, hepatitis A, B, and C, and tuberculosis and HCV by supplying people with safer using supplies and safer sex supplies. So, we beat the anti-stigma campaign back in the early 90s with the condom distribution. And we've been working on changing a lot of the stigma around the others, because when we got syringe exchange, it was because people were sick of seeing the needles in the gutters. And in order to stop that, we started this program, and it has been wildly successful. It is a rarity that you now find needles just laying around, and that is a big boost to safety to everyone. Now, just imagine what could happen if we can get drugs decriminalized in the District of Columbia, because that is the mission that we're on now.
Excellent. As we have about 25 minutes left of our session today, I want to return to some of the questions, Tamika, that you posed to our audience. I'm going to read them again. And what I think would be exceptionally helpful and useful for our audience members to do is consider these questions and perhaps enter some responses to these questions into the chat box below the video screen today. And then we can kind of review some of the responses that we receive and talk through those submissions and maybe ways that those can be expanded upon. The first question, which I really like, Tamika, is what have you, our audience members, as healthcare providers, as policymakers, as administrators, as community members, as coalition members, what have you assumed that your clients wanted or would be satisfied with? And what is the real reality, and where are those differences? And perhaps, Tamika, as our audience is entering some answers into the chat, you can provide maybe an example from your lived experience, either as the client or as the provider or the community support, community builder. That's something that you can share there as well.
I'll talk from a provider side because it's as a healthcare provider as well. We work with a lot of people that are Hep C positive. And we have been working with National Institute of Health for a couple of years on a program to treat them with medication that eradicates hepatitis C while they're actively using their drugs. Very innovative program, very high success rate, 96% success on cured our client base, while NIH had a 76% success rate. So we effectively proved that you can treat people that are actively using their drugs by having conversations with them and showing them that we're working with you through your drug use. Just come in and see us when you have a 24-hour period that you're not choosing, so we can get your urine sample and give you your next set of medications. And it's worked. And we have cured 96% of the patients that came through our clinic. And it was because we met them where they were, and that meant being able to send them a ride to get to the office or going to pick them up. This is the innovation that is needed to reach people to make sure that you're doing your part in making sure that they can get healthy. Because people that use drugs want to be healthy. I know I do. So that was how we took and met the community where they were. And we still try to meet the community where they're at. We're expanding our services. We started out with one van. We have two now. And we're looking to do a third, possibly a fourth, because we're looking to try to have our services 24 hours, 7 days a week, so that we can round the clock meet the needs of the people wherever they're at.
Thank you for that. We've gotten a handful of responses put into the chat to the question, which is, what did you expect versus what was the reality? And most of the responses, or many of the responses, I should say, focus on or touch on the idea that I assume these individuals are providers or prescribers in some capacity, that their patients or their clients wanted to go immediately into full recovery or full abstinence or sobriety, and then realizing that not only was that sort of a lofty and daunting and intimidating goal, there is also an aspect, especially for certain substances, of like clinical medical issues with doing that, difficulties as far as going into withdrawal and having to deal with other quasi-related medical issues. So I think that's a really important distinction, right, between what we perhaps as healthcare providers or healthcare administrators have sort of been indoctrinated to think, the ultimate goal should always be just immediately stop using any and all substances, abstinence and full sobriety should be the goal as soon as possible, as quickly as possible. But that's really not a reasonable or attainable goal for many individuals. And it's not necessarily a goal that all patients want, per se. I think there's something to be said for people who can have and lead productive lives while still using substances. That just, using substances or having substance use in your life doesn't immediately discount you from being a productive member of society or a positive member of your community.
That is true, because everybody does not have chaotic drug using history. There are people that have absolutely no problems at all. And that is the issue there, is that we're lumping everybody into the same box, and I had crack using issues and trying to adhere to that can't use anything ever again approach was not working for me, and I feel for people that are on other substances that have to be weaned off of them. And that's why, again, our clinic provides services for people that want to do medicated assisted treatment, to wean them off of these substances. And that is a process. And that process can take a long time or it can take a short time. It depends on the person and what their desires are. I know for me, I wanted to stop using crack cocaine chaotically, and that was a priority for me. But then, just quitting all substances was not something that worked for me. I wanted to arrest the chaotic behavior, and the chaotic behavior became controlled because I stopped using crack cocaine. But I do still smoke marijuana, and I do have a drink from time to time. And I don't have chaotic behaviors behind me because I also did some footwork that wasn't even part of conversations in those rooms that pushed the abstinence up. And that was mental health care. I arrested some of the behaviors that propelled me to use because I had a hole in my soul, and I fixed that hole. It works for some people. Abstinence only works for some people, but it's a small population. When harm reduction works for everybody, everybody has the same opportunity to reduce harm to themselves if the tools are made available to them. And 9 out of 10 people will take those tools. Well, 10 out of 10. Because who's going to turn away free tools to make getting high easier? No one, unless they're afraid that they're going to be stigmatized or somebody's going to call the police on them. But we don't have that issue in DC. And I would like that issue not to be anywhere in this country. We need to look at changing these drug policies so that we can stop stigmatizing people and let folks do them. You might be surprised, a lot of these people will flourish if we weren't criminalizing them.
That's an excellent point, and it actually ties in very nicely to another audience response that we got to that prompt. It's a little bit long, so I'm going to try to paraphrase it, but it's basically that this individual, this audience member, only ever encountered her clients or their clients after the clients were referred by either Child Protective Services or some other justice involvement. So that the clients did not necessarily want to be there in and of their own volition per se, but in order to either remain outside of the criminal justice system or not be incarcerated, they needed to kind of check the boxes. So my question to you, Tamika, I would love to hear your thoughts on, how do we work with other systems, right? How do we work with CPS and the carceral system and the justice system to create more cohesive and productive avenues of treatment and support for these individuals that can actually be useful, right? That allow the individuals to your point, sort of self-define what their end goal is, what their version of recovery looks like.
Stop taking people's children away. That's not helpful. If anything, it will exacerbate the problem and make people go harder using their drugs, and it gives the perception that they don't care when it's painful to folks not have their kids with them. So taking their children is not the answer. If anything, direct them to mental health care first and foremost, and provide them with the support they need to get back on solid footing. But then if we're not breaking down the systems that put people in the positions that they're in, number one, remove the penalties for drugs. They're not productive. Remove the penalties for drugs. I mean, that's going to be a resounding thing for me, is to remove the penalties for that, because if we don't, then We're not going to be able to ever get CPS out of people's business. People they should have a right to make choices for themselves and still be able to raise their kids. If they want to use drugs, fine. Just find a way to do it in at least chaotic way. And if that is a problem for them, then still make access to treatment available if they choose, and not coercing them into it. Court system has no business being in a lot of people's families. Family court is not unified. It pretty much destroys family structures to have them in their business. Again, I would definitely have to point people to mental health care ahead of involvement by the court systems. And definitely stop calling the police on people. If you have some concerns about what's going on in your neighbor's house, why don't you go have a conversation with them and ask them, how can I help? Is there something I can do to help? Is there something I can refer you to help you? Where can I support you? Instead of sitting here doing this. You. And not knowing what's going on with them. You don't know if you don't ask.
Absolutely. We actually got another audience question, not a direct response to the prompt, but another question that I think is wonderful. It is, as a patient or as a client, what is the way to most effectively build trust with a provider or with a service delivery mechanism that allows success? So a lot of what we've been talking so far is the opposite, right? Is the other way around, which is how do we as clinicians or administrators or the resource work with clients? This question is the other way around, which I think is very interesting. How can clients or patients work with those trying to deliver resources to them, whether those are healthcare or social or psychological resources, in a way that builds trust, bidirectional trust between the patient or the client and that resource?
I know if I'm not comfortable in this space, I might not be willing to talk. So if the atmosphere does not come across as welcoming to me being talkative, I'm going to come in and I'm going to be there just for what I need to be there for, and I'm going to leave, but I myself, I'm a bit different than a lot of people. I will talk to my provider because I'm trying to pick you. I want to see where you're at, because I want to make sure I'm getting the best care, and a lot of people will just take what they get because they're so used to people being, I guess, shitty facilitators of that care, that they just don't say what's on their minds. And it's because there's not an atmosphere created that welcomes people making suggestions. I talk to my clinicians. I don't have a problem with that, but that doesn't mean that other people don't feel a little off-put and being able to come into a space and feeling like they have a voice that will be heard when they come into these spaces. I don't have a problem coming in and talking to my doctors. I talk to them from the beginning to the end. Even when I go for blood work, I talk to them because I hate needles. And I have conversations with them because I'm trying to talk myself into being comfortable and getting ready for this needle to stick me. And I'm like, hey, you good at this job? How long you been doing this? I'm talking to them the whole time. Okay, why haven't y'all find a way to get this blood out of my arm without sticking me yet? Things like that. Trying to lighten the mood. I make myself comfortable with some things, and then, like, if I have things I need to talk to my doctor about, I try to remember everything that's going on since my last visit, which can be hard because I work so much. And I'm older now and I get a little forgetful, but me personally, not an issue. But then that's because the clinic I go to has always been welcoming, and it's because they specialize in dealing with people like me. And that isn't the case in a lot of places. They don't have clinics specifically to deal with people who are HIV positive or that are transgender.
Excellent. I think we have time for one more audience question, and then I have a couple of kind of wrap-up questions for you as well. We have a question in the queue here, specifically about safe injection sites and what the efficacy is of safe injection sites, what the trajectory of those should be. Should those be included in middle-class neighborhoods, poverty neighborhoods, where those should be located, and how can those be leveraged in such a way to help reduce stigma and increase patient trust in the system?
It shouldn't only be in the inner city. The drug problem is just there now. Common sense would be to make them. I don't like that sterile clinical kind of thing. That is just not welcoming to me. Because drugs are social. It should be like a bar, lounge, hookah bar thing. And that in and of itself, taking it out of that sterile type of environment for the few examples that we do have, kind of takes a lot of that stigma away, because it's more of an adult entertainment space, which is what it is adults use drugs. And to have a safe place for them to use them is a no-brainer, because just like the bartender in a bar that sells alcohol is a safe distribution site and they can monitor your alcohol use and know when to cut you off, well, the same could be said about a safe consumption site. It should be another space that is for social use and not something as stigmatized and wanted to be put in a little back alley out of sight. It should be normalized and brought to the forefront because, truth be told, people use drugs.
Very well said. Thank you. So we have about 5 minutes left. I want to kind of pose two kind of wrap-up questions to you, Tamika. One, what is a main or a handful of main critical action steps or takeaways that our audience can take from this session today, and how can they implement that in their setting, whatever that may be? And then the second part of that question is, where can our audience members go for more information, for more resources, for more guidance, for more expertise?
Oh, definitely come to HIPS for the expertise and the advice. I'm not going to send you nowhere else, baby. If you need my email address, I'll drop it in the chat. But yes, definitely treat people like the favorite person in your life. Treat them like the one person that you love the most as they're coming into your clinic, because like when people come to HIPS, I'm a hugger. I hug our clients. I swear to God. I welcome them with a smile. They're coming in, being greeted, and warmly welcomed in. Do y'all need something to eat? You got some food? This is how we kind of operate, and we have a successful model. And I've made these same type of suggestions to people that are looking to provide clinical services in a harm reduction manner. Have it being a welcoming space. People come to our clinic, to our office, even when they don't have anything to do and just hang out, because it's a safe space. It is a safe space. They can come, and we have a gamut of folks. They're not just all LGBTQ. They're not all just transgender women. We have cis straight folks come here and just hang out too, because it's a comfortable space. Be welcoming. You want the community to come to you first and foremost for their healthcare needs or their harm reduction needs. Welcome them.
Wonderful, beautifully put. Well, thank you, Tamika, for your thoughtful commentary, for sharing your story, and giving us so much actionable insight this afternoon. I and the planning committee, and I'm sure all of our audience members, are so appreciative of your time this afternoon. This was a wonderful session, a wonderful workshop. To our audience members, this does conclude our breakout session on exploring how anti-stigma work is predicated on anti-racism. We are going to move into a brief break before our next session, which is our innovation session. It is a plenary discussion. It's the only thing going on. It will begin at 3:20 Eastern time, and that will be in the plenary and breakout A tab. As a reminder, once again, instructions for claiming continuing education credit will be provided at the conclusion of the summit this afternoon, and all of the sessions are being recorded and will be distributed to all of our audience members upon conclusion of the summit as well. As always, once again, it's been a pleasure to host you, Tamika, and our audience members for this session. Please enjoy the rest of the summit programming if your schedule does allow.
Thank you.